job. The description of surgical techniques and presentation of results. Chia-Feng Chen.
Okay, thank you, Zuren. Morning, professor and colleagues. I'm the 6th-year resident Chen Chia-Feng. Today I'm going to present a very special case for the facial gender confirmation surgery, which we haven't performed in our center yet. We focus on the lower jaw, the description of the surgical clinics and the presentation of the results. So it is just published last month on the Plastic and the Reconstruction Surgery Journal, and from a team of a facial team group in the Bali International Hospital, which was located in Spain. So nowadays, the transgender patients have an association, and they have the regular published guideline called the Standard of Care of the World Profession Association for Transgender Health. And now we have the 7th edition of the guideline and in all kinds of language, including Chinese. And they are very detailed, include how to manage this, how to try to manage the patient with the transgender needs, how to confirm if they are and the indication for surgery, how to do the surgery, and how to do the medication treatment, how to evaluate all the medications and transgender surgery outcomes. So in this standard care, we can see they include the surgical management and to see what kind of surgical management are included. So for the male to female patients, surgical procedures should be include like the breast, the chest, augmentation mammoplasty, the genital surgery, of course, for the osteotomy, vaginoplasty, all kinds of vulvoplasty. And for not genital or non-breast surgical interventions, nowadays, facial feminization surgery is indicated for all kinds of transgender patients. So for this, according to these associations, patients need to accomplish all kinds, like including the breast, the genital surgery, and the facial surgery to accomplish the transgender surgical management. So in tradition, the facial gender confirmation surgery includes several parts, including the lower jaw surgery, the forehead surgery, which reduction the forehead and reduction the eyebrow area prominence, and also do the rhinoplasty to get the ala smaller and the kind of shape the dorsal sides. However, previous studies have been focused on the forehead much more and the rhinoplasty, but that's attention had been paid on the lower jaw surgeries. So for this paper and group, they want to focus on the clinical indications, diagnostic methods, surgical planning, and the surgical techniques for the jaw and the chin line contouring for a patient's need to transgender from the male to female. There's study designs. This is a retrospective study. All trans feminine patients that underwent facial gender confirmation surgery at their center. For these patients, they do also the pre-op and the post-op 3D computer tomographic scannings. And they also do the questionnaire since October 2016 for items including the facial femininity and the masculinity, self-perceived and as perceived by others. Also the pre-op and also the questionnaire was done pre-oply and the 12 months after surgery. And they use a 7-point Likert scale to range the very masculine to very feminine, the facial appearance. So how they do the surgery? All the patients was done under the general anesthesia, nasal trachea intubation, and intraop, they do the osteotomies by ultrasonic micro vibration technique, which we can see the picture at the right side is the piezo surgery flex. I think we have this kind of tool in our center too. And they also use a planning tool called the Nemotech, which was incorporated with also a Spain company to do a lower border supported cutting guide that was printed in the biocompatible material to help them do the precise intra-op marking. And we can see that kind of precise marking better in our pictures. For the post-op care, they do the cooling therapy from the first 24 to 48 post-surgical hours. They also offer a manual lymphatic drainage from the day 2 to day 5 after surgery. And they also ask patients to do the compression surgery over face for at least 4 weeks after surgery. So first, we need to identify what kind of face is a feminine face, what kind of face is a masculine face. For the anatomic considerations, areas for chin contouring surgery should be included chin, the mandible body, angles, and the ascending ramus. And what's the feature of the male gels compared to the female gels? So I try to find the two beautiful people, which was recognized as a very feminine as Lin Jilin at the left and the masculine as Jin Xiaowu at the right. And so we can see their mandible contour is quite different, including the Jin Xiaowu had a greater body height, border ascending ramus, and so the male had a mandibular angle formed by the body, and ramus tend to be more accurate. So 侧面, we can see the picture downward and more square-shaped chin. So the facial conformation surgery over the mandible need to change from the more squared and more prominent body height and the bolder ascending ramus to a more feminine contour. How to do the surgery? So first, we need to know what's our goal for the transgender family surgery on the mandible. First is to decrease the transverse and the vertical jaw dimension, and also try to modify or soften the gonal angles, and to contour the jawline, to change the volume, actually to decrease the volume and the format and the position, the chin a little bit anterior. And secondary need for soft tissue tightening if the patient is too old and the chin ptosis appeared after the surgery. So first, they divided the surgery into several parts, including chin or the mandible body and angle. For chin, they do a vestibular incision, and the incision made between the canine to canine or lateral incisor. And they also do the subperosal dissection, identify the mental nerves and protect them. So why I do this? Because their approach for explore the mandible is a little bit different from us, how we do the OGS surgery. They do a triple approach. And for the mandibular body and angle, they do the bilateral vestibular incision at the level of the first and the third molars. They do the periosteum over the ascending ramus, body angle is detached. So in this paper, they focus that they do a combined treatment of mandible body angle chin with a triple intra-op approach without detach the soft tissue above the mental nerves. So this is the picture the left is the picture how they explore the mandible area with 3 openings. And the right side is they demonstrate this on a cadaver dissection. So for the traditional mandible contouring, the all mandible areas are exposed, and which cause the excessive exposure of the mental nerve and cause the post-op numbness and all kinds of discomforts. But they try to preserve the soft tissue and the mucosa above the mental nerve, which they think will be improve the post-op numbness a lot. And how they do the shavings? They using two kinds of methods. One is the burr and one is which called the piezo surgery technique. Burr, so like burning in the mantonian area also make it possible to modify the format, like decreasing the anterior posterior projections. And but the disadvantage, including the exposure of the cancerous bone, may cause the bleeding and the irregular bone surface, and hard for the surgeons to explore and see clear intraocularly. So they have a table to describe how they do the osteotomies and osteotomies. They do all kinds of bone cut under the assistance of the lower border supported cutting guide. But they didn't demonstrate how is the cutting guide look like. But we can see how they use it. So for the excessive mandible angles, the pre-ops, they found that, and they do the osteotomy must be complete in both cortical, including the buccal and lingual side, as well as in the tricortical area of the posterior ramus, in order to avoid the back split in this level. And for a patient with a very large mandible, lower polar, so they do the angle-to-angle resection. They use it when necessary they approach the entire mandible surface as a unit and cut to leave a symmetrical contour on both sides, and be very careful. Leave at this place the same level on both buccal and the lingual surfaces. So this is how they do the mandible angles. They use the ultrasonic cutting technique, the piezo surgery technique. And the osteotomy should be complete in both cortical, including the buccal and lingual side. And also they use a rich endoscope, the striker's endoscope, to assist the posterior ramus cut. And this is the mandible angle they removed from the mouth. It's quite big. For the combined treatment of mandible body angles and chins, the patient who need to do the angle-to-angle osteotomy, that's how they perform that. So in the picture, we can see a black line here. This is using their cutting guide to assist marking the cutting area, and then they cut it under the pencil surgery technique. So once the entire jaw are in, so this is how they do that step by step. Once the entire jaw and chin are exposed, then the bone burr is complete, and then they do the planned osteotomy carried out by the ultrasonic technology. The cut should deliver a symmetric contour on both sides and should be placed at the same level in both the buccal and lingual surface. And it's preferred to divide the bone fragment into 4 parts to facilitate its removal, since they don't open up all the mucosa. For the chin areas, including chin tapering, the vertical reduction, advancement, or augmentation, they have this kind of surgical methods. So first, how to do the vertical reduction of the chin. So they do a basal osteotomy and then transition the mandibular body be as smooth as possible. And the modification of the position of the chin, they do the ultrasonic microvacation cut. And then they realign the mantelus muscle in its proper anatomic position. If the patient have a lot of chin reduction involving the inferior border, they will do an extra step to reinsert the omohyoid muscle with the bone anchoring sutures, try to help with suspending the submentalis tissues and decrease the risk of chin ptosis. So this is how they cut the chin and do the reinsertion of the muscles and close the wound as we do in the OGS patients. So the results is that they do this kind of surgery since 2010 January, and collected patients until 2019 February. Among the 110 months, they treat a total 837 transfemoral patients. It's quite a huge number for jaw and the chin surgery. So the mean age was quite young, ranged from 18 years old to sometimes 17, but the average was 39 years old. And the patient mainly comes from Europe, but lots of patients also comes from the US. The Asia patients are quite rare, not quite developed yet in our country, I think. And the patients, also 15% had patient had smoke habits, and most of patient has taken hormone therapies when they do the surgery. So this is the table to count for what kind of surgery patients had already have. So a total include among the 837 patients, a total of 793 patients also underwent one or some of the following feminization surgical procedures, including the forehead reconstruction, which was done in most of the patients, simultaneous hair transplantation, which this is also quite important, but only 150 patients do that. And also rhinoplasty was 1/3 patient do that, and the malarplasty was less, only 56 patients. And also some patients have the lip lift in nearly 200 patients, and the Adam's apple contouring in the 1/3 of patients. So total of 2,700 procedures were performed for an average of 3.2 procedures per patient. So these patients did a lot to make themselves more likely to be more likely to look like a woman. So how is the result after their approach and the mandible contouring surgery? This is the femininity perception satisfaction. So the patient give the scores to, one is that not like a woman, to 7 like that the patients feel themselves was quite feminized. So 3 questions were asked. One is, how do you perceive your face and your chin and jaw, and how do other people think and perceive your face? So the pre-op score was only like 47, but after 1 year of the surgery, the patient think the femininity perception score increased to 76, which was significant improvement after this kind of management. And how their satisfactions. So 3 questions also. One is the overall satisfaction of the surgical results, the satisfactions over jaws, and how rate the level of the satisfactions of the jaws. So the overall satisfaction results was 7.73 after the surgery. And the follow-up duration was from at least 1 year to 110 months. So because this kind of patients was quite special, so they also calculate the duration of follow-up and compliance. And every patient come back for the immediate in-person follow-up consultation 10 days after surgery. But the patients got lost, most of the patients got lost follow-up to only 5% patients come back to the hospital to do an in-person follow-up, and some got follow-up abroad using a telephone or video conference. So that means we should be very careful manipulation and very careful when seeing this kind of femininity perception score, since probably they have a less sample size compared with the pre-op. and the patient satisfaction, because if the surgeon is satisfied, probably they won't come up, or if they are satisfied, they are willing to come up. However, they didn't mention these kind of details in their paper, but now we want to check the follow-ups and communications, including the pre-op reoperations and also some modifications and revision surgeries. Reoperation, because of problem detected during the post-operative period, occurred in only 22 patients, not very much. And the most common was the irregularity of the mandible contouring. So they come back to do another contouring surgery. And the post-op surgical hematoma was noted in 5 patients, and they all received a surgical drainage, and the condition improved. Local infection was even less in 3 patients. Also, they all received a surgical drainage to improve the infection condition, and the final result was okay. So most of patients had a low to moderate surgical edema that responds very well to control cooling surge therapy. So I think it combined with the post-op cooling therapy, lymphatic massage, compression therapy, which helps a lot for the post-surgical edemas of the mandible contouring patients. And most of the patients also had paresthesia over the lower lip and chin area, though they try to preserve the mental nerve, try to not to expose these soft tissues. But all patients had the spontaneous resolution between the 4 to 30 weeks after the surgery. And currently, no permanent damage to the mental or inferior dental nerve. Of the patients whose operation include the use of surgical guide, I thought they used that in all patients, but not only 200 patients. 11 experienced a sagging skin due to they need to release the soft tissue to put the surgical guide inside to make the excise intraoral markings. 11 patients experienced the saggy skin, subcutaneous tissue, or submental musculature after surgery. But we don't know if this is all related to the surgical guide, or probably because the patient had a very excessive reduction of the chin, and probably the patient is quite old with a relative inflexible skin, but that didn't mention the details in this paper. So then we are going to see the pre and post-op results. So this is a clinical case before and after facial gender confirmation surgery. Surgical was performed including the forehead reconstruction and bioconal approach rhinoplasty and lower jaw contouring with the angle to angle osteotomy and chin tapering with vertical reduction. So patient was quite satisfied, and I think surgeon was quite satisfied too for the post-op outcome. So they showed up these patients as a post-op results. And they this is another patient who did the pre-op 3D scan, and we can see also the post-op 3D scan, which show us the procedures including the forehead reconstruction by conal approach, simultaneous hair transplantation for the bilateral frontal areas, lower jaw contouring, angle-to-angle osteotomy, and Adam's apple contouring done in a time. The patient was quite satisfied. And the last case, this is a case before after the forehead reduction, the rhinoplasty, the lower jaw contouring, mandible angle only, chin tapering, and the vertical reductions and Adam's apple contouring. So patient and the surgeon also very satisfied with the results. So in their center, all the 3 patients do the surgery in the time, including the forehead rhinoplasty and the lower jaw surgery. But I don't know if they do the Adam's apple contouring at the time or not. So now goes to the discussions. Their approach, they focus a lot on their intraoral approach, which is based on the tunneling and not complete exposure of the mandible nerve, but completely expose the mandibular base from a triple approach, which, unlike the traditional deglobing technique proposed by the other authors, triple approach protects the path of the mandible nerve and branch, in addition to producing less scar tissues intraorally and the post-surgical fibrosis. And for the tools for osteotomy, which I have mentioned in the beginning of this presentation, the ultrasonic technology or the piezo surgery, the Park and Lee proposed a mandibular angle osteotomy using a saw, which was traditional using a saw or either burr. And Zhang et al. Use a round burr to mark the osteotomy line and then cut it. And in their team, they do the osteotomy, including the burr first, and then using the ultrasonic technology. So they think it ensures the better control of the osteotomy because of the horizontal parallelism of the cut and the cortical level, both buccal and the lingual sides. And they minimize the possible damage to the structures adjacent to the bone because of the inherited characteristic of the ultrasonic cut. And they change a lot. In their study, they try to change all kinds of head of the ultrasonic tool, all kinds of cutting head, try to fit the angles of the parallel to the cortical areas to cut them. However, some disadvantages also mentioned in the paper, including more expensive because it takes time and higher learning curve and slow. But I think it deserves because the ultrasonic technology provide them a precise and smooth cutting lines over the jaw. The second is the vertical reduction of the chin. So there are some methods try to do the vertical reduction of the chin. Previous published was by this Dr. Wolf in the plastic surgery in 2007. So he's probably a famous, I think he's a famous craniofacial surgeon, and he tried to use the transverse and vertical dimension, try to use the remove the middle part of the chin and put the lower part of the chin back to protect have the bone graft to protect the contour of the original chin and using the burr to modify the chin contours. But the reduction, he only removed the middle part, immediate part of that, and do the fixations by the plates and screws. So this will, like the pictures I've take from his paper will seen below. So this is how Dr. Wolf do that. And this will bring some questions according to this Spanish team. So this will first, the excessive structural weakness of the fixed symphysial fragment with the possibility of bone necrosis and probably not well bone healing, and the risk of damage to the dental roots and the mental or inferior dental nerve. And this needs a greater technique complexity because you need to cut both upper and lower and make it very smooth and symmetric bilaterally. It's harder than you just cut the lower part. And they need the need for plating osteosynthesis materials because you need to put the lower part of the chin back. Also, this so if you want to do the vertical reduction of chin, you can do another way to sliding genioplasty, just to cut it and put it back. Not only do this to improve the all kinds of chin contours. Then also the Dr. Wolf, I see his paper, he also used bone graft or standard or customized implant to correct the chin projection and the chin problems. So for the for the bone contouring and bone genioplasty methods, the soft tissue is also a problem because some patients develop the perimandibular soft tissue ptosis, also the jowls, after the surgery. So probably the patient need to have the surgical repositioning of the mylohyoid musculature to the bony ridge of the chin and tighten the redundant skin and sagging musculature with the neck lift. So in their team, if the patient has lots of chin reduction, they do either the simultaneous or delayed neck lift. All patients older than 45 years old undergoing this kind of surgery, larger than 50 millimeters reduction, were informed about the potential ptosis. And sometimes if the patient want to watch for weight, they will wait until 1 to 1.5 years after initial surgery. And they also mentioned some older patient probably will develop ptosis several months or 1 year after the initial surgery. So probably they can do the neck lift, or they can do a non-surgical management, including the high intensity focused ultrasound or radio frequency to help with this kind of ptosis. And this is the end of the paper, and they also mentioned they are nowadays not published yet, but working with a special software that makes it possible to produce a virtual design of any type of osteotomy and obtain a lower border supported cutting guide, which provide a greater control over the cut. So to reduce the complexity of the surgical technique and to decrease the surgical times, and try to simulate how the chin and also the soft tissue looks like after the surgery. So this is the facial confirmation surgery report today. And any questions or any discussions? Thank you.
Yeah. Yes, any questions? Can we invite Dr. Zhou Bangyun? Can you
Yes.
give some comments and questions?
Okay, thank you, Dr. Lins. Actually, this topic has been reviewed previously by our fellow, Dr. Alan Yan, in OGS meeting. At that time, Professor Yuri Chen wanted Dr. Yan to collect all of this kind of facial gender affirmation surgery in our meeting, because this is a very hard issues in the future. I think this is really a very hard issue in the future as well. But as Dr. Chen has noticed, we have to collect all the list, all the patients they want to receive such kind of a surgery, especially for those already receiving of the endocrine or the hormone therapies in our centers. And in the future, this is supposed will be a very prospective field, and we have to explore it. Not only focus on the contour for the chin, as well as probably all over the zygomatic area or the forehead area is all a possible field to focus. So in this paper, I think that's because they all focus on the center in the span, and they could collect around 800 more patients. And actually in our craniofacial center, we are lacking of such kind of patient in our center to collect it. So we only focus on the anterior part of the chin, but we have no experience for the chin angles and all the mandibular body and all around of the lower part of the mandible. So for me, I have no one of this kind of experience for this, but so we have to try to go out to approach it. So this is the society or this is the community. Thank you, Dr. Lin.
Yes, thank you. And Professor Ray Chen, can you give some comment?
Yes, I think this is but we need to study a little bit more by taking combined CT or 3D CT to study the normal contour of our Taiwanese mandible shape or Asian mandible shape. The second is that with the software, the cutting guide, I think we can develop our own. I know that Dr. Zhang Chengxing, Dr. Frank Zhang, and did some cutting guide for angle resection or low border resection already. And some of our colleagues that practice outside do mandible angle or body reduction doing with cutting guide. I think this is a good tool as well. Well, for genioplasty, that's the discussion where the patient, the other one, that Tony Wolf, that this one, actually this patient have a double jaw surgery that the 4-1 surgical split and rhinoplasty at the same time. I think it's a different type of genioplasty compared to the only contouring of the mandible body for femalization. This is then this patient need the OGS and then come back to our specialty as well. And for femalization only, I think we can study more of the mandible shape of the female, the average, and if possible that we can develop our tool of the cutting guide. And then surely, as Dr. Zhou said, that we should do more about the diploma reduction and forehead reduction and this kind of information among our center or among the Taiwanese. I think this is a future development for all you young surgeons that you can focus on. Thank you.
Thank you. Frank, Dr. Zhang?
Yes.
Can you give some comments?
Yeah, I think as Professor Yuri Chen said, this is a field that we need to explore and develop our cutting guide in our center. We have advantage that in different Spain that they only do chin contour. We also do the sarcoma reduction. In the Western country, they less likely to do the sarcoma reduction. However, in Oriental people can do the sarcoma reduction. I just have very few patients with frontal contouring fat injection, sarcoma reduction. And moreover, for the sarcoma reduction, we have a 3D simulation system so that we can measure how much reduction in each side. Because most people has a symmetrical sarcoma projection. In this way, we can reduce one side more than another to make the face more symmetrical and more harmony. And for mandibular angle resection, the cutting guide before was done by my assistant. Since I don't have any assistant more, right now our dentist, for example, Dr. Liao Yufang, has this kind of service also to do the cutting guide for us. And moreover, in our hospital, we have contract with the radar. It's charged about 20,000 yen. And you charge the patient, you do the CT scan, and you send the image to them. Then the technician will discuss you that how is the cutting, how much, and the curve. Then they not only print the cutting guide, they also print the entire lower mandibular border. And this company is only one of only 2 companies has the Taiwan government approved for the GMP lab. So we can use this safely. So we have 2 ways. One is as favor our dentist. Another way is do the commercial cutting guide. But we don't have the data of normal female contour. So this is the future that we should develop the contour. Right now, it's just you just feel the patient want such actress contour, so you just do it manually. So I think in the future we might have better advancement in this field. Thank you.
Thank you. Indeed, we have a lot of female patients. Probably we can generate some fundamental data from those data, and then to compare between the female and male. Professor Lo, do you have some comment?
Yeah, I had some experience of this male to female gender transform skeletal operation before, and I feel that I remember very well that one of the patients told me that if he has a successful surgery and then he in his group, meaning male to female, and in Taiwan at least 2,000 people in the circle. So this is actually quite a potential field that some of you could develop in the future, and you can attract a lot of patients. I think the main issue that so far we have limited number of patients is that most patients focus on the sex organ, or body transformation, such as the pineal manipulation or the breast surgery, like this, and their secondary consideration then turns to the facial part. But I think that with some successful cases, and also in the media that people know that we can do a good job, I think we can attract more patients. So some of you could really develop this service and then attract more patients. Thank you.
Thank you. Yao Yishi, Dr. Yao, do you have some experience in the transgender surgery?
Actually, no. So I have no comments.
Okay, thank you. Thank you, everyone, and so we can further.
I still have one small suggestions.
Yes.
So as I echoed Professor Lowe's, for this is a really potential area, because for the previous versions of the standard care of this transgender health association, they only recommend they suggest the patient all have to do the breast and the general surgery, but the non-general surgery, non-breast surgery was only, they put that into recommend the patient to do that, but not 就是他们没有说一定要这样做，他们只是建议。But nowadays, they're sure they will publish the 8th edition of this kind of standard care, and they will put they already announced that will put the breast genital surgery as well as the facial conforming surgery as 3 most important parts to have the patients transgenders for these kind of patients. So in the future, these patients need to accomplish the breast, genital, and also the facial surgery to become female, from male to female. So I think these surgeries and these patients and need will be increased in the future. And also not likely the breast and the genital surgery, the patient need a lot of pre-op psychosocial evaluations. The facial feminism surgeries did not, they did not suggest these kind of regular psychosocial evaluation before the surgery. So probably it's more easier for patient to reach us and have the surgeries, and more easier for us to do that.
Yes, if we want to do that, we probably need to create a center, a transgender center, to create a multidisciplinary collaboration and then do the service. Okay. So thank you, everyone. Then we may proceed to the second part. Dr. Lin, she would introduce the neurofibromatosis medicine.
Hi, good morning, everyone. Should I present in English or Mandarin?
Yes, please.
Oh, OK， 好。我今天不好意思，我今天其实不会花各位太多的时间，我今天大概就是过一些 N 词的 criteria。那当然就是因为主要当时是因应义诊，那么以目前我知道好像是义诊会暂时先暂停，因为疫情的关系。不过还是快过一下，让各位知道一下我们 N 词 criteria。那么后续如果说有一些病患在咨询的时候，可以透过医师，各位在线上的医师快帮我们跟判断一下。那当然也跟病患做一个沟通，来避免一些后续一些算是期待上面的落差。好哦。好，那我们现在讲 N 词，我们在 AZ 内部我们讲的就是 EAP， 就是我们 Early Access Program。那当然就是我们的诊断主要就是 NF1， 然后有症状，而且是确定由医师这边判断是不能手术的。那当然这主要就是也带到我们的药证，因为我们的药证的话，这个是我们的药证。那我们药证主要就是 NF1， 然后有症状，而且没有办法手术切除的 NF1 的 PN 的儿童病患，所以他必须要在13到18岁。那么我们的核准的药物，我们公药时间是3年，所以从 AZ 的核准日起算，比较不会是被 IRB 或者是 TFDA， 但是被 AZ 的核准日起算，因为这样对我们来说是比较好算，那就是3年为止。那当然当中就是要邀请临床医师或者是护理师或者是个管师等等帮我们进行院内的 IRB 申请。那我们这边都会提供院内 IRB 申请的相关的文件，但是要请各位帮我们跑流程。那我们在整个 AZ 药品是 AZ 的，但是呢，我们有委托包含了在新加坡的 vendor， 就是 Craniofacial， 还有在台湾的基地，会帮我们进行药品的配送、物流、安排班机等等。好哦，那所有再强调一次，就是有症状的不能手术的，那么 AZ 需要符合一些 criteria， 那我们会有一定的剂量的计算，依照小朋友的体表面积。那么什么时候结束呢？就是包含了我们拿到 reimbursement， 那或者是3年，那另外还有就是一些临床的表征，例如说 disease progression 或者 toxicity 等等。那这边就是比较重要的 IE criteria， 跟各位临床医师带一下，就是过一下。那这个我们不会太严格，其实我们 AZ 内部在审核不会太严格，原则上只要小朋友，因为我们已经拿到药证了，所以小朋友只要各位临床医师判断觉得适合，他没有一些符合，他没有违反 IE criteria， 基本上很快就会给过，那大概5天之内就会合格。那他要有一些 PN 的相关的一些症状，比如说是神经压迫、外观，或者是有一些肢体活动等等，或者是疼痛，这一些基本上我们都有算在内。那再来的话就是体表面积，我们刚刚提到 我们会有依照体表面积去计算它的所需要的剂量。那一天是2次 Q12H。在这边呢，我们希望他的心脏、血管、血压等等心血管功能要是正常的，这个是要请临床医师这边帮我们帮我们留意的。Exclusion criteria 的部分呢，我们希望他没有在其他用药的一些副作用，希望是没有的。那之前也没有服用过，这个是在台湾是一定会符合的。另外还有就是眼睛的一些症状，那他的眼压必须要是正常，所以希望可能在这之前，如果可以的话，就是由眼科医师帮我们做评估。那么另外，他不能有 optic glioma， 因为这个也会是 NF1PN 的小朋友容易发生的症状。那另外还有一些恶性的肿瘤，那也不要现在正在进行癌症相关的治疗。那后续这些在申请里头跟 AZ 申请里头会帮要申请的医师开通一个 Craniofacial portal。那这个 portal 就是需要请医师帮临床的案例帮我们上传到 AZ， 那 AZ 在5天之内就会核可，所以其实我们会很快就核可。那么一旦 AZ 这边核可，再加上院内的 IRB 申请也核可，我们取得进口核准函之后呢，刚刚提到的基地，他们就会开始安排班机配送，去把药送到台湾来。那后续的话，大概就是一些比较细节。那后续只要这边一申请，我们后续 AZ 相关的流程或者是沟通的人员就会很快进来协助，包含跟药师那边协助。所以这个会是一个很快的关键，很重要的关键，就是医院跟 AZ 的流程都必须要并进。那另外这边就是一些比较细节了，那这边我就不过。那另外一个呢，这边是刚刚提到的 Craniofacial 的一个系统，那么我们会帮医师申请账号。那么抱歉，我再回来一下，申请账号的我们会请医师提供一些像是英文姓名、服务单位、联络电话、email、medical license， 那么填写一个简单的一个表格 ，New Customer Account Form。那这是新加坡那边 Craniofacial 提供的，那么这是整个网页的操作，相当单纯，那也是还蛮容易的，不会花太多时间。那最后呢，我要带一下，如果在治疗过程当中会有一些 AE 的话，也请帮我们上到 Craniofacial 这个系统，帮我们填写 AE 的 reporting form。那因为上回提到在 Craniofacial 小朋友的治疗里面会有一些 AE 的情况，那么这些也就是请各位临床医师在跟病患沟通的时候帮我们带到的，就是包含了有点像是皮肤、腹泻、消化道的症状。那后续只要临床医师有申请案例，那么核可了，后续就会再跟治疗的医师再约一个时间，过一下这一套就是还蛮漏等的一套 slide。那么这一套 slide 呢，我们主要就是针对Craniofacial 恩慈用药跟病患的卫教准则，那其实里面有蛮多细节的。那当然，如果说回到各位专长是外科的话，大概我们有一张 slide 会带到跟手术有关系的，就是什么时候停药，那什么时候开始恢复用药。那今天我的部分大概就是这样子，就是包含了 IE 的 criteria 以及后续。AE 如果有 AE 发生的话，帮我们填写 AE reporting form。那这一些是 AZ 会在收集的部分。那我的部分大概是这样子，谢谢。不晓得各位有没有什么问题？然后公药是3年。
谢谢林博士。
谢谢。
那请问各位医师有没有什么样 comment 或是问题呢？林院长。林志荣院长，
对不起，我刚刚上线，前面的报告我没有听到。那据我所了解，这个药物，在美国已经用一段时间了，大概有好像4、5年吧，有一段时间。那在使用的过程当中，很多病人都会有胃肠的症状，会恶心、呕吐、腹痛、腹泻这样的症状。那甚至病人会，我看还有病人因为这样休克的情形，所以说很多病人用到一半之后，他就没办法持续的使用下去。 那这是并发，这是使用的一些药物的反应的问题。那第二就是说它的改善，很大部分病人都只有部分改善了，那顶多是一半的改善。那而且病人他这个药物的使用不能持续的使用，只能一个阶段使用，他没办法长期使用。据我所了解，请教这3个问题。
好哦，谢谢您。美国的话呢，它是在2020年的4月，它取得核可了。那应该很快就上市了，所以它大概是20。那台湾的话是在去年的12月取得了。那对我们目前还没上，我们估计在今年的下半年会上市。那么在您第2个提到的是在 safety 的部分，其实确实 safety 的部分呢，会有一些副作用。那么副作用其实最主要的就是您刚刚提到的，一个是皮肤，一个是消化道。那之所以会是在皮肤的原因呢，主要是因为它阻挡了 ERK， 它是 ERK inhibitor， 所以它其实会影响到一些角质形成细胞的一些保护防御机制 migration， 甚至造成它们 apoptosis。那这是一个。那所以在整个治疗的过程当中，小朋友会容易有一些皮肤的症状。那至于在消化道症状的话，我呈现这个给各位看。在这边会有一些在消化道症状的部分，主要也是因为一些signaling pathway， 然后导致胎长的一些影响，所以最后容易会有腹泻的情况。但是呢，如果整体来讲，抱歉我会跳来跳去，但是整体来讲，在我们整个 A1 里面，大部分的 A1 其实都还是落在low grade， 就是 grade 1跟 grade 3。所以在这边像您这边可以看到了，虽然说我们的在整个临床试验里面，我们大概3年多的时间，从2015年的8月开始收案，那在我们 data cutoff 是2019年的3月，我们收了50个小朋友。那到我们收 data 的时候呢，大概有21位离开临床试验，那里头呢只有5位，他们是因为 A 而离开的。那这个是，所以大约是10%。所以回过头来，刚刚您提到的 safety 大概都是落在 low grade。那至于休克的话，目前在我们的临床试验，我可能要再去找看，因为目前在我们临床试验的数据里面，还没有看到相对比较严重的副作用。那我再带一下您刚刚提到的 efficacy 的部分，我们在这些治疗的小朋友里面，其实它的 PN 肿瘤的缩小，大约平均来说是缩小了27.9%。那它的成长是正2.2到缩小了大概一半，有高达55.1%，大概是这样子的落差，平均是27.9。这个是在 NF1PN 的治疗。那如果我们跟我们临床试验数据来跟我们之前有呈现过的就是 NCI 的这个数据，这个 NCI 的数据，它治疗的是 NF1PN 的小朋友，在没有治疗的情况之下，它的 PN 的成长的速度。所以您看哦，相较之下，这个是没有治疗的小朋友，而且一样是儿科的小朋友，93位。那一样是儿科的小朋友是观察了平均6.8年。那可以相较之下，可以发现有使用 selumetinib 的这一群 population， 它的 PN 的成长呢，其实可以被很明显的压制下来。那么我再快呈现一张 slide 给你看哦。这边是这个啊，是我们最新，我们的切点是切在去年，我们算是最新 up to date date， 切在去年的2月。那这个时候呢，所有的治疗小朋友已经治疗有长达5年之久。那这5年之久，其实可以发现这一些治疗的小朋友，他的 better response 是蓝色的部分，所以我们其实可以观察到，大约还是有，估计大概有7成多的7成多的小朋友，他们的 PN 其实都能够受到还不错的控制，大概是这样子，给您参考。
但病人常常这些小朋友，我知道那时候做很多都是小朋友，那小朋友的 side effect 是蛮普遍的。那但小孩子对这些 AE 的 tolerance 相对是比大人更 suffering 的，那也困扰。虽然说这个的 tumor 会减少一半，那一般来说我们常常在一些人都大家都讲都减少一半，但事实上减少一半对 patient 他的我不确定说他的改善对，以及他这段期间所要付出的这些的不舒服，像皮肤的一些这些那个症状哦，那皮肤的症状呢，有时候会痛，那很不舒服。那对这样的话，是不是要用什么药物来控制，而可以控制得下来，让病人持续的治疗？那这些病人持续治疗的时间能有多长？
哦，谢谢你。这确实因为我们服用的药物是小朋友，所以我们对于 A management 这一块，我们其实非常非常的重视。因为像之前提到，就是如果今天这一些小朋友他们在服用之后，他们因为 A 的关系停药，最后会导致肿瘤的生长。那这个是在我们临床试验里面，就是有一个小朋友他在治疗13个 cycle， 每一个 cycle 是1个月，治疗13个 cycle 有达到 partial response， 17个 cycle 有得到 better response， 但是他在21个 cycle 因为 grade 3的 AE， 所以他剂量有调降，所以可以发现这边 PN 它的成长就又回来了。因为我们可以理解它是一个基因特性。那么回到刚刚您提到的，对，确实我们甚至会提供这些数据，我们非常的就是很诚实的跟临床医师还有跟病患这边提供这些数据。我们确实可以发现消化道症状真的是最普遍的，大概最普遍的。那现在台湾我们甚至有一个16岁跟一个18岁，他们也是皮肤症状很快就出现了。那所以像回到刚刚院长您这边提到的治疗，我们其实在这边我们都会有一些肠胃道，比如说我先拿肠胃道为主，我们在肠胃道不良事件的发生率的这个 session 里面呢，其实我们都会让医师们知道说，我们在临床试验里面这个副作用它在治疗第几个 cycle 的时候，它发生的比例是多少，然后它的症状是多少，以及一些相关的临床照护。那在这边呢，如果以腹泻来看的话，我们会有分级，主要的原因是因为不一样的分级会影响到后面的用药。那比如说像这边您看到的是，我们会有一些建议的常规用药，当然甚至呢后面会有一些像这样子的一些 flow 会。这些是我们 Global 给的一些建议的资料给临床医师参考。那当然，我们也是尊重台湾的临床医师的判断跟台湾临床用药的一些常规。是，这个是腹泻的部分。那另外还有另外一个很常见的，就是在皮肤的部分。那皮肤的部分，我们这边也会有相关的一些治疗。那有分不一样的等级。对，那这些提供给您参考。会议不一样的 AE， 不一样系统 AE， 然后会有不一样的主题在这一套 slide 里面。
因为药物的进来，我想很多的家属，很多爸妈都非常期待。爸妈，那他们常来门诊会问到这个问题了，那他们很愿意试。如果说很多的家长，愿意试的话，或许我们会有我们的 data， 那看看我们的台湾的病人到底是这些小朋友治疗结果怎么样。那治疗其实大部分都是大部分都是年轻的小朋友的时候比较值得做这样的治疗。我想，对他们来说这是一大福音。谢谢。
谢谢。那目前我快 update 一下，我们目前在台湾大概有将近，目前包含正在申请的大概有20位。那他的皮炎长得有在脸上，在脊椎，那有的在长在内脏，然后长在额头。那好像也有长在接近视神经，那我们也很期待 就是看看半年之后这一些小朋友的治疗，那我们会持续跟临床医师做追踪。谢谢。
好的，谢谢大家。请问主委有没有什么 comment？
本来这个礼拜六是我们用实体的方式在分享一下这些资讯嘛，那么大概我们现在用线上来做，那么主要是由我们的神经儿科的，什么意思啊？那大概我们要决定一下，其他的医师们要不要在线上参与，或者是用什么方式来参与？这是给大家一个建议，就是说长庚的这些病人群，我们大概也应该提供他们一些机会了，那只是这个机会而已。那所以我想林院长或者是 Nancy 那边要帮忙决定一下，邀请哪些医生们线上也稍微参与一下，在9点半是吧？这个礼拜六9点半。Nancy 还在线上吗
？9点，这个礼拜六9点。
好，那么可以的话，我想林院长还有大家关心的人，可以线上去参加一点。那当然，我想最重要是鼓励我们这些小孩子们，可以的话能够参加了，因为这毕竟对于我们 Craniofacial 的几乎每个病人都有症状，几乎都没办法开刀，因为小孩子事实上也不晓得要开到什么程度，所以大家都 indicated。我相信再可以配合的话，我们尽量参与，这是个机会。那希望这个真的对长期来讲有知道一些好的结果，那是最好。谢谢。
谢谢主委院长，还有林医师、卢医师的安排。那我们再提醒一下，因为我们6月底我们的恩慈会结束，那也请各位临床医师帮我们看看，我们还可以帮助多少小朋友。6月底要关了，谢谢。
谢谢林博士。
谢谢卢医师，有没有什么问题？还是卢医师？
就看那个 Nancy， 我觉得如果是线上的话，就像主委建议，就是可以多找一些医生，就是有参与的，像是我之前是不是有中医的也有啊？中医
有，
对，好像中医也有参与，就是不然请那个蔡月如医师，因为他手上也是有一些有关眼睛附近的病人这样子。
蔡医师那天有事情，所以没有办法参加。
好的，那就大家一起加油喽。谢谢 Dr. Lin， 谢谢。
谢谢各位。
谢谢你。那我们 meeting， 今天 meeting 就到这边，谢谢大家。
谢谢，拜拜。
拜拜。